Good afternoon. Thank you for joining us today for Collaborative Approaches in Elder Justice for Protecting Adults Living with Intellectual and Developmental Disabilities, or IDD, or Dementia. My name is Ashley Hawes, and I'm the Director for Consumer Information at Benjamin Rose Institute on Aging. This session today is being offered as part of the Administration for Community Living Alzheimer's Disease Programs Initiative Project, expansion of dementia-capable communities within urban and rural settings in Ohio, using evidence-based and informed programming. Today's webinar will be recorded. During the webinar, you may submit a question at any time using either the chat feature or the Q&A button at the bottom of your screen. We have staff monitoring the questions in the chat. To convey your questions to our presenters during the Q&A portion of the webinar after all of our speakers have presented, and to answer any technical questions that you may have. You can turn on captions by selecting Live Transcript, the button with two C's at the bottom of your screen. We are conducting an evaluation of our dementia education sessions as part of this project. You should have received an email with a link to the pre-session evaluation questionnaire, which also contains further information about the evaluation. If you did not have a chance to complete the pre-session questionnaire, we ask that you please complete this now using the link provided in the chat. By doing so, you are helping others in your community. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. I now have the pleasure of introducing our speakers for this afternoon's presentation, Dr. Ronan Factora, Ms. Natasha Pietrocola, Dr. Jess Bibbo, and Ms. Courtney Reynolds. Today's speakers are esteemed experts in the field of elder justice and will highlight their work that focuses on protecting those with dementia and developmental disabilities. You will learn about collaborative approaches, innovative solutions, and the latest research aimed at ensuring the dignity and safety of older and disabled adults living with dementia and other impairments. Our first speaker for this afternoon is Dr. Ronan Factora. Dr. Factora completed his medical school training at The Ohio State University College of Medicine and Public Health, his internship and residency in internal medicine at the University of Pittsburgh Medical Center, and his fellowship in geriatric medicine at the Cleveland Clinic. He holds an appointment as associate professor at the Cleveland Clinic Lerner College of Medicine at Case Western University. He is a member of the physician staff in the Center for Geriatric Medicine and Program Director for the Geriatric Medicine Fellowship at the Cleveland Clinic. Please join me in welcoming Dr. Factora.
Thank you, Ashley, for that introduction. I'm just going to go ahead and share my slides. Are you able to see it in presentation mode?
Yes, we can.
Okay, very good. So this first part of the talk, I'll be talking about the elements of the virtual capacity evaluation that I typically conduct with Adult Protective Services to address individuals where there are concerns about elder abuse, neglect, and financial exploitation. So the goals for this particular module is to become familiarized with the cognitive testing and interview questions used for capacity evaluations, and then also understand the rationale for the recommendations following such evaluations. So the important thing really, we have this appointment set up to see these individuals virtually. And there's a lot of prep that takes place before the evaluation. And a lot of this information revolves around gathering baseline information about what a person's been doing at home, how a person's doing in the community, and the concerns. And a lot of this background that I get, I rely upon Adult Protective Services to actually provide. So the information that actually is provided, there's a lot of information that I can get. A lot of this comes from the community. There can be police reports and EMS reports where there are concerns about abuse, domestic violence, or physical abuse, or wandering that may come up. There are reports from the community, neighbors, maybe even financial institutions about neglect or abuse or exploitation. The Adult Protective Services staff, when they actually go to the home, they actually can look at a person's medications and see how old they are and do pill counts. And that pill count can tell me whether or not that person has been taking their medications properly or consistently. They can also take a look to see if there's any signs of bills that are paid or unpaid. That information may also be provided by the facility where a person may be residing in, unpaid rent. There may be some hints that utilities have not been paid by the presence of no lights and utilities or appliances not working. Looking around in the environment as well, there may be some food in the home or lack of food in the home or expired food in the home, too much food in the home. There may be clutter in areas of egress, which may raise concerns about safety. There's also concerns about the physical condition of the residence. There may be some walls that are in disrepair, sinks that are leaking, toilets that are not flushing, the presence of hoarding, and the presence of vermin. So cockroaches, bed bugs, mice, rats, and then in some circumstances where hoarding is an issue, pets, lots of cats, lots of dogs, lots of birds. Oftentimes we rely on this collateral information to give background for me to know how a person is doing in the community. In clinic, I'll often rely on family members and friends to provide the collateral information, but in many of these circumstances where I conduct these virtual capacity evaluations, family members may not be present, they may be absent, or they may be concerns that they may actually be the perpetrators, in which case the collateral information provided by them may not be as reliable. I can also request for information to be obtained in agencies, other healthcare facilities where a person may have been getting care to get background information on the most recent medical visits or medical conditions that that person may have that would justify the use of certain medications, or that may indicate that certain medications should be taken on a regular basis. Now, fortunately, I have access to a medical record system that allows me to access a person's medical records for other health systems that also have the same health system as me. And I have Epic, and that gives me some more background, but there are some other agencies, certain hospital systems and the VA that don't have Epic, and I have to find those records otherwise. So the preparation for the visit, we have to be all available at the same time. So that's the main thing. So is the client available when we're going to conduct these visits? So we have to have some overlap. I typically conduct mine on Wednesday afternoons. We also have to make sure that they have Wi-Fi or internet. If they live in an apartment complex, that may actually be more available. But if not, then often we'll use a hotspot for Wi-Fi that is brought by Adult Protective Services. I ask our APS nurse to actually get a set of vitals for the person's here, so blood pressure, pulse, and weight, because any indicators of weight loss may also suggest that there's some self-neglect going on. A person's either not eating regularly or has poor access to food. And then conduct that medication review, get a medication list if there's any way to do that before the visit. And then take a look to see if there's any concerns about safety. There may be some clues, like burned pots and pans, broken doors. Problems with obstruction of entranceways, exits. If a person's using an assistive device like a cane or a walker, is there a lot of clutter? Are there a lot of obstacles? Are there lots of ways where a person can fall? There's other challenges as well that we encounter. There's concerns about pets. Are they going to allow these visits to take place? There are other persons that may be in and out of the home that are not residents there and are maybe taking advantage of that person. That can be a concern as well. So safety for my colleagues that go in and go to that person's residence, their safety is important, and it's not unusual for them to request, when appropriate, police to accompany them, especially if this is something that is mandated by the court. So the next step, once we get this squared away, we conduct the evaluation itself. And I do this in conjunction with the APS nurse, whoever's across on the internet, and they help me out with this evaluation. It's hard to do this myself. So the medical evaluation really has several elements. And one is to, if I have access to the medical record, see whether or not there are any medical illnesses that that person has that are documented, including the presence of any mental illness, depression, anxiety, bipolar disorder, schizophrenia, to see that could be contributing to a person's cognitive impairment. And I can also get a sense of whether or not that person's seeing their physicians on a regular basis if I have access to their medical records. And then I also can see whether or not certain medical conditions can lead to impairments in cognition if they're uncontrolled. For example, if the person has uncontrolled sleep apnea and they're not using a CPAP machine, that can lead to problems with cognition. If they have a history of depression, and they're not taking their medications properly, the person can have problems with concentration and focus as a result of that. If a person's been hospitalized recently, they may be suffering from delirium, and that can be the primary reason for the referral. They may have cognitive impairment underneath that, and it can be hard to separate the presence of delirium and disentangle that from underlying cognitive impairment. So getting that appropriate history and those medical records helps to clarify what is going on for the people that I'm seeing. And then a review of the medications, particularly to see if there's any side effects or interactions from the medications themselves that can contribute to a person's cognitive impairment. So I look at all the elements that could be producing cognitive impairment for the person that I'm evaluating. Now, on top of that, there may still be undiagnosed medical problems, particularly for people who have not seen a doctor in years, and that's not unusual. And there may also be undiagnosed mood disorders, individuals that I have no access to medical records for, and they have no medications, and there's no way for us to know that a person has a long-standing history of schizophrenia or bipolar disorder, or if they do have a diagnosis of dementia and no one has really been informed. So there's a lot of unknowns when we try to conduct this evaluation. So we're just trying to dig to get a clearer picture of what is going on. So I asked the person several questions to get a sense of what that person's life is like in the home. And I asked them first and foremost who their usual doctor is, just to get a sense of whether or not they're getting medical care. Because I have access to the medical record, but if this person is getting care from a doctor just down the street, someone who is not affiliated with the Cleveland Clinic or doesn't have an EMR that I have, I wouldn't be aware of it. They'd be able to tell us who they see, where they are at. And this also allows the APS to reconnect them to medical care after we are all done. In the backdrop of all the information that I get from APS, I also ask that individual what their functional status is. And this gives me a sense of whether or not that person understands that there's any impairment or not. So I ask them very basic questions, and I tell them that I'm not being insulting. I just want to ask them, are they able to take a shower and bathe on their own? Are they able to pick out their clothes? Do they get dressed? Do they shave, brush their teeth, comb their hair, wash their face, take care of their person? Do they do their own house cleaning? Do they do their own laundry? Can they cook? Do they go to the grocery store? Are they managing their own medications? Are they managing their own finances? Are they using any transportation? Are they driving? And this gives me a sense of whether or not this person believes that they're able to do these things independently. And then, invariably, I see these persons because they have some cognitive issues. So I ask them, do they have any memory problems? And I also ask them if they think that their memory problems are affecting their ability to function. And then I ask them specific questions about whether or not they have depression. Have they experiencing any weight loss? Have they been experiencing any symptoms that may be associated with dementia? For example, hallucinations, seeing little people, animals, bugs, hearing voices, noises, asking them whether or not they have any paranoia feelings. Do they feel that people are listening in on their conversations or plotting against them? I also ask if they're having any problems with tremors or shaking, problems with sleeping. And then, have they been having any problems with walking or falls? Have they been to the emergency department or the hospital recently? And all these questions are gauged to see whether or not a person understands their current situation, has an understanding that they have some of these problems with their memory or their mood, and to demonstrate any appreciation that these issues are affecting their functional status. So these elements are all important in trying to build that case for whether or not a person has decision-making capacity. Then I ask more details. The purpose of this interview really is to try to collect information so that I can be convinced that this person really is as independent as they say they are. So I ask them, if you're taking your own medications, can you tell me what medications are you taking? What are the names? Do you know how many pills do you take? What are you taking the medications for? When asking about the finances, and they say they pay their bills on their own, I ask them, well, what bills do you pay on a regular basis? How often do you pay them? As adults, we expect to be paying things like the utilities, credit card bills. We have to pay a bill for our cell phones. We have to be able to go into the grocery store, pay for gas, pay insurance for our cars. These are all things that everyday individuals should be aware of, and we would expect any adult to be able to answer the same way. Now, if a person says they're going to grocery and they're saying that they're getting food for themselves, I might ask them, what do you buy at the store when you do go? How often do you go? How many bags of groceries do you actually bring home when you're all done? And how long does that last? And I try to match what they purchased at the grocery store with what they're eating. So I asked them, what did you eat last night for dinner? Or what did you cook this last week? And if they say that they're cooking, and see whether or not there's a match. I also asked them if they did get sick and they were in the hospital, do they have someone they would trust to make medical decisions for them if they were, for example, sick with pneumonia and they weren't able to make decisions for themselves. So this gives us a sense of who they trust in their life to make medical decisions for them. And this also gives us a way to link to their family or friends in the community that we can maybe engage in, and also help them, help us take implement a plan of care for them. And then I asked them some questions about judgment and planning. Ask them some questions about safety. For example, what would you do if there was a fire in the kitchen? I'm trying to see whether or not they would be able to try to put out the fire or leave the area. Who would you call? Do they know 911? Do they have a life alert button? If they have a life alert button that's kind of hanging from their chest, do they know what it's for, and what would they do in that circumstance? And it would not be unusual in some circumstances for people to not even be aware that that's there. They wouldn't know what to do in case of emergency. And for me, that really raises the specter of whether or not a person is actually safe being alone at home. And then, questions about future planning. Now, whether or not they would accept help if they needed help to do things like the laundry or the cleaning or the cooking. If for some reason they weren't able to do these on their own, or if they needed help with bathing or dressing, would they accept the help? Or if they got so impaired, for example, if they fell and they broke their hip, that they were no longer able to transfer independently, would they consider moving to a more supervised setting where that care could be provided? And these questions give me a sense of whether or not a person, again, understands their living situation, but can also anticipate their future needs in scenarios where they may no longer be able to function and live independently in their current residence. And then I asked them for their reasons why they would or would not actually choose to accept help or accept moving into a living situation. And people are allowed to make decisions on their own. And as long as they're able to provide a reason that is reasonable, not necessarily one that I would agree with, that would suggest that they actually have thought things through and that they do have reasoning behind their decisions. Again, all important information when I'm trying to determine whether or not a person has decision-making capacity. So that interview take a while, but then after that, I do some more formal cognitive testing. And the purpose of the testing is really just to quantify and identify the presence of any cognitive impairments. So I employ a number of different tests. So for this virtual capacity evaluation, I use the St. Louis University Mental Status Exam, or SLUMS, as an overall testing for cognition. I screen for depression using the Geriatric Depression Scale. It's a short form. We do clock tests and trails A and B. So I'm just going to go through those real quick. Some of you may already be familiar with some of these tests, so I won't go through them in detail. So the SLUMS, it's 30 questions. There's several domains that are actually implemented here. A lot of this person should be able to actually answer with regards to orientation. And these questions, I ask one at a time with the help of the nurse that's over there in their residence. And then we tally the scores, and I can see how they would rank. I also get the person's baseline level of education, so I know kind of, are we contending with someone who has completed high school or a bachelor's degree, or have they only been able to achieve a limited level of education? And that gives me a sense of whether or not the score may reflect education more than anything else. The clocks tests are pretty straightforward. We have a person draw a clock, one with the circle, one without the circle, to see whether or not they're able to use visuospatial skills and executive functioning. This is a score out of 15, and we see whether or not they do well with this as a test of visuospatial skills and executive functioning. And then the trails test. And this is a test, again, of visuospatial skills and executive functioning. We have a person actually connect the dots, so to speak, alternating between numbers and letters to see whether or not they're able to connect them all in order. And impairments in this may also suggest a reason why a person is not able to plan or organize their daily activities to get things achieved and done. And then, of course, we do screening for depression with the depression Geriatric Depression Scale, the short form. This is 15 questions, all yes or no. We try to get as clear an answer as we can from the individual. Now, the more cognitively impaired a person actually is, the less likely that this is actually going to be able to detect depression appropriately, because their ability to understand the questions becomes more impaired as cognition actually advances. This does require more abstract thinking when you're thinking about these questions and the answers that you would give. So when you're thinking about the domains that are assessed, this is really where you can see where there's overlap in the tests that we do. So with the St. Louis University Mental Status Questionnaire, it assesses orientation, attention, memory, and that's immediate working, as well as visuospatial skills. With the CLOCKS test, it's visuospatial skills and executive functioning. With TRAILS A and B, it's sequencing and executive functioning. And the Geriatric Depression Scale, screening for depression. This is actually the model that was implemented at Baylor by my geriatric colleagues there, and we've used it here. The rationale behind this, really, the cognitive testing is really to have an overlap in the domains of cognition that are impaired. If there is impairment, just to show uniformity. A person may not do well in one test and they may do well in another. It may suggest that they just didn't understand the question properly or weren't able to do things properly. But if you have the same domain affected in two different tests, that really suggests that this is a real impairment. So that overlap in areas of cognition that are tested, that overlap in impairment really supports the idea that there's true impairment present in those domains. And then documenting where the domains are present are important, once again, for me to do the capacity evaluations. And then I try to put this together to think whether or not this supports my understanding about that person's answer to the questions, or whether or not, if there's impairment, are the cognitive domains that are affected supportive of the reason why that person is impaired. So the cognitive evaluation, when we interpret it, there's a total score, and there are standardized cutoffs, normal versus abnormal. And then you can actually adjust, in some tests, the score based on what you would expect and not expect based on the levels of education. So, for one example, the mini mental state examination, the normal cutoff is 26 is normal, but you can adjust that score to a lower level of cutoff if a person has a lower level of education. And there are similar types of cutoffs for other types of tests. Now, it helps me identify areas of cognitive impairment, and then whether or not these impairments, when we link back to my interview and the medical evaluation, does that help to support the things that I'm seeing when I'm interviewing the patient? Does the presence of cognitive impairment kind of go along with my thoughts that person lacks decision-making capacity, particularly with finances and with medical care? So we put all of this together. I asked three different questions. Is there functional impairment? And that's based on the initial evaluation, information that's provided by APS as well. Is there cognitive impairment? And that's really based on my cognitive assessment. And then, is the functional impairment due, or at least partially due, to the cognitive impairment? So this puts everything together, because you have those two linked to have a diagnosis of dementia. And that's really what I'm looking for. Is functional impairment due to cognitive impairment? And then, the different issues that I kind of look for: does that person demonstrate understanding or lack of understanding that there is cognitive impairment present, and that's affecting their functional status? And then, do they have an appreciation for that impairment and its impact on their functional status? Again, it's based on the questions that I ask, and whether or not that person demonstrates reasoning as to why they would or would not accept help, why they think that they're able to do things or not, why they're accepting help to do certain things at home or not. That appreciation helps is what I'm able to garner when they ask those questions. And then the rationale for their decision making, for the answers that they give to me, that explanation, I have to see whether or not they provide at least some kind of logical reasoning behind that, particularly when they're trying to explain to me whether or not they would accept help in the home, whether or not they would move to a more supervised setting, why they would refuse care, and then how would they actually get the care if they were not able to get their basic care needs met, obtain food, pay for the bills, get their medications, get transportation to their doctor's visits. And then the communication element as well. Are they able to communicate to me clearly their understanding, their reasoning, their explanations? A person who's got expressive language dysfunction, they're going to have a hard time. And with all of these questions, if there's impairments, that's when I wonder whether or not they really need to have someone else to act in their best interest. Okay. And then when I'm all done with this, I reconnect with the team again after we've done the completion to see whether or not, determine whether or not a person has capacity or not. We also raise any concerns about safety and whether or not the person really should be living alone, and whether or not there should be more, a quicker action taken to get a person in a safer environment. I also suggest an appropriate medical workup if I don't have access to their medical records, to make sure that there's no reversible causes of cognitive impairment that haven't been investigated yet. And then when it's appropriate, I complete a statement of expert evaluation when really there's gonna be a pursuit of guardianship to be expected. And that is often the case when I see these patients up for these virtual capacity evaluations. So key points. Cognitive testing is used to identify cognitive impairment, but does not determine if a person does or does not have capacity to make medical financial decisions. There are specific questions focusing on insight and judgment regarding functional status, and these are necessary elements in determining decision-making capacity, in these circumstances. And last point is that collaboration with APS really facilitates development and implementation of this plan of care. So that being said, I'm going to stop sharing and pass it on to Ashley. Thank you.
Thank you, Dr. Factora. Our next speaker is Natasha Pietrocola. Ms. Pietrocola has spent over 19 years in social services addressing diverse issues in the field of aging, including community-based long-term care, elder abuse, and social advocacy. She currently serves as a board member with the Consortium Against Adult Abuse and is a board member with Ohio Coalition for Adult Protective Services. Ms. Pietrocola currently serves as the administrator for Cuyahoga County Division of Senior and Adult Services, which includes the Adult Protective Services Program that manages the reports and investigations of allegations of abuse, neglect, self-neglect, and/or exploitation of impaired elderly residents 60+ years of age who reside in the community, as well as vulnerable adults 18 to 59 years of age. Ms. Pietrocola holds a Master's of Business Administration from Cleveland State University, a Master of Education and Community Counseling from the University of Toledo, and a Bachelor of Arts in Psychology from the University of Toledo. Please join me in welcoming Ms. Pietrocola.
So thanks for asking me to come and speak today. I am going to kind of talk about the origins of this program from an APS perspective. I'll give a brief overview of what the Adult Protective Services does in our particular state, and then I'll talk about the benefits of having this program and this relationship that we've developed with the Cleveland Clinic. Next slide. So really quickly, this is the Ohio Revised Code. So this pertains to all 88 counties, but Ohio is a home rule state. So APS may look a little different county to county. But protective services is defined by the law to be something provided to an adult who has been determined by evaluation to require such services for the prevention, correction, or discontinuance of an act of, as well as condition that might result from abuse, neglect, and exploitation. In our particular county, the most prevalent call that we get, and there's multiple dual referrals and reports and allegations sometimes that we discover once we get into the case, is self-neglect. And self-neglect itself is embedded in the neglect criteria. So that's why it's not mentioned here, but it is definitely defined in Ohio law. In Ohio, we have a few criteria that's a little different from across the nation. We are one of 2 states that investigates 60 years of age or older. The person must have some kind of impairment or disability. It can be functional or cognitive in nature, or a combination of both. And we don't expect the person making the report to be able to pinpoint and say, yes, they definitely have dementia. It could be something like you notice ambulation issues, you have a history of diabetes, some health concerns, or the suspicion of something going on cognitively or mentally. And there must be the allegation. And the allegations, again, are abuse, neglect, self-neglect, and/or exploitation. And a combination is also, like I said, very common. Next slide. Oh, sorry, and I had a fancy slide here. They also must reside in the community. In the state of Ohio, we do not have jurisdiction to do investigations in a nursing home, although we've had nursing homes and long-term care facilities call us when somebody leaves against medical advice. And then when they return to the community, we would open that case. Next slide. So what was our decision to really create this unit? First and foremost, something like the pandemic occurred in April of 2020. And it really took us for a loop because we were accustomed to doing a variety of things to get somebody assessed. We could request a protective service order from the courts, or we could work with a physician and people. Sometimes we were able to get into their doctor's offices, but a lot of that stopped. Unless there was an emergency service being rendered, a lot of these appointments that were not critical were canceled. There was inability to get clients to see a doctor, whether it's their primary care physician, or even connect them with a psychiatrist or connect them to a geriatrician. So we had to very quickly think about how we were going to base what we do in APS. And a lot of what we do in the course of our care plans and our treatment is really contingent upon whether somebody has the functional ability and the cognitive ability to make decisions. It impacted our court. So we went to a Zoom system with court hearings, where in the past we would show up and there'd be hearing dates, there'd be, our clients would be served and other family members served when there were hearings that were coming up. And we saw a change in the court. The court didn't skip a beat. It was just that we weren't used to that familiarity of that relationship that had existed for years. We also noticed that we had clients who obviously had questionable capacity concerns. So we'd go out to the home and we may suspect something during the investigation, but we couldn't pinpoint what was going on, and it really required a medical expert to take a look at it. There's always an emphasis with anything that Adult Protective Services does on least restrictive versus more restrictive. We always balance autonomy versus safety. And we've gone into obvious situations where there are immediate risks to a client that we have to tend to. It could be physical in nature and they need emergency medical treatment, or it could be some questionable behaviors that we have a lot of concerns with: wandering, driving. Oftentimes our workers are trained in APS that when you go out to a home and there's a car and we suspect that there's been accidents, what do? You view the car. You see if they're hitting the garage. Are there parts of the door that are dented or the bumper falling off? A lot of key things that really can signify that something may be going on with our client. So we always try to, err on the side of providing services around a person, keeping them in their home, in their community, with just some support if at all possible. But there are times that unfortunately the outcome of the care plan has to be a little bit more stringent and may even require a guardianship or a placement. We also hope to minimize court involvement. We've seen some of our court numbers go down as far as protective service orders. In the past, if we had a client that was non-cooperative or we had a very difficult time getting to an appointment, and sometimes we would try over and over, and the appointments are sometimes very difficult to come by, we would pursue a protective service order. But with this process, we thought to ourselves, if a nurse comes into the home and the APS worker potentially also attends that appointment with the nurse, and we have a doctor there that is live and they may have a different kind of demeanor with a physician, we found that some of our clients enjoy speaking to a doctor. It doesn't make it feel, or a medical professional in general, it doesn't feel as social worky or threatening. We also wanted something innovative. We've talked for years about somehow trying to figure out how we get a geriatrician into the home, but we've never had the financial resources to pursue that. So this was a perfect storm with actually a positive outcome. And because it works so well, we've just continued to have this relationship and foster it. And next slide, please. So there's a lot of benefits. And if you are attending this webinar and you hail from an adult protective services program and you have access to nurses in your agency, or you can work out some kind of arrangement, it really enriches the experience. Most of our social workers obviously have that type of background, but having somebody with a medical background who really speaks the language of a physician is beneficial. Now, most of us in this field have learned lingo throughout the years, but it's just not the same. There are prescription benefits that a nurse can look at. Like Dr. Factora mentioned, our nurses go out. Kelly is our particular nurse. She has a stethoscope. She can do blood sugar readings. She has a scale to check people's weight. She surveys the home, and getting into the home and then speaking that language and also conveying that as a medical professional to a client sometimes is beneficial, and the clients sometimes listen a little differently. She also helps with the medical assessment piece. There are some cases where the nurse, and she has 3 staff who work underneath her, who are all licensed social workers, going out to the home. She has gone in the past, and the nurse has kind of evaluated wounds. She's taken blood pressure. She does some things that really are more in her wheelhouse than it would be a social worker's purview to engage in. There's a difference with the APS social worker in the home with them. We try to build a rapport with our clients. Obviously, we want them to trust us, and we want them to understand that we truly are there to benefit them. We want to see a positive outcome. Positive outcome doesn't always mean that somebody's going to be institutionalized or placed in a nursing home. That is not the end goal of adult protective services. It is very difficult to find nursing homes, let alone meet criteria to be eligible for long-term care. So we're always looking at alternatives of just keeping a person in the home as long as possible, with alleviation of any kind of abuse, neglect, or exploitation we may discover, and remedying that. They can also share with the physician the client's environment. So oftentimes we've heard in the past, when somebody goes to a doctor's appointment, they have a tendency to clean up. And if you have a perpetrator involved with that particular case, they also kind of clean up their act. So with the nurse going into the home, we give the doctors a bird's eye view of the conditions. Is there hoarding? Are there different kinds of environmental hazards? Are there issues with utilities? Is there food in the cupboard? Is it expired food? Is it appropriate food, especially if somebody has a medical condition and they shouldn't be, eating certain things with their diet? We also can help with the coordination of laboratory appointments. Sometimes, and this is more in Dr. Factora's expertise, but there are times that clients have deficiencies, or they may have a medication issue that is creating some of the confusion, or something else may be going on. But being able to order that lab work and work with a nurse and a medical professional to get that organized, and then also drawing in the social worker from APS, is helpful. And our nurse also goes out, and the same with her behavioral health staff, and they survey the environment. They see whether there are fall risks, if there are pets in the home. I know that there's a whole different kind of scenario that you may hear some more about, but just about the care of the pets. And that can indicate that something's going on and people are forgetting things, feeding, overfeeding, those kind of things. Next slide. So Dr. Factora went over this, so I'm not going to go into this in great detail, but when we began this program, we looked at it like at the end of March, the beginning of April of 2020, and we met several times to talk about what were some of the tests that would be used for the screening. So our nurse got herself very accustomed to some of these tests, the clocks, the mini mental status exam, the trail making test. All of these, as mentioned earlier, do kind of provide a different perspective about where somebody may be cognitively. But these are, like referenced earlier, some of the things that are done between the nurse going out and the physician doing the actual assessment. Next, please. So why is cognitive testing so important? There are times of the day when you can go and visit a client and they will be clear and lucid and really present well. But we also know that not everyone shows cognitive change in the same way. And that's why we kind of look to these assessments to see, are there issues with remembering? Is it something with applying information and then being able to analyze it, then being able to utilize that to do things? Can you understand directives you're being told? Can you create something that when you're giving information, you know how to meet a goal or an ends? We have many clients who remember very well, but there's functional parts of their cognition where they can't take medication appropriately, or they're unable to manage finances, more of the higher level, maybe executive functioning that we see some deficits, but still can be detrimental to the overall well-being of our clients. Next slide. So this is what we do from the APS end when these virtual assessments occur. We first decide when the APS worker goes out, whether or not the allegation is validated. Is there abuse, neglect, self-neglect, or exploitation going on? What kind of evidence is the worker seeing that is leading us to this conclusion? Does the report made really match what we're going in there investigating? Sometimes we go in there and we find something totally different. Sometimes we find additional allegations that are occurring with the client. So if the client does start to exhibit some signs that there are capacity concerns, but they may not be connected to a primary care physician or any doctor for that sake. It might be just getting them into appointment. Is it timely enough? And so if we start to see that, yes, there's some deficits, we're not sure what they're stemming from, we may opt to decide to pursue a geriatric assessment and ask for the nurse to help do a consult. Also, are there other people involved with that person's life? Do they have a surrogate decision maker already, a power of attorney? Do they have a spouse, a child or a grandchild who checks in on them, siblings, neighbors, whatever the case may be? Or has there been concerns about capacity to the level that maybe in the past there were questions about whether or not somebody may need a guardian and a legal decision maker? And if the case plan warrants further assessment, this has been a great opportunity to get our clients in front of a physician to actually have a full-blown geriatric assessment accomplished. And then we can order, like mentioned earlier, tests, blood work, things that are also necessary to get somebody to a point where we understand truly what's going on with them. Next slide. So what we do prior to requesting this, we develop a case plan. We try to talk with the client about what our concerns are. We obviously go in, we don't reveal who the referral source is, but we talk about what are some of the details in the report and what the concerns are. And we try to get them to understand that this may benefit them. We look at whether or not the client can make appropriate, safe decisions without somebody else intervening. And then we also base some of this on the report. Is there something that has been reported in the past? Are there concerns that we're seeing that mirror the report? Are there additional concerns? Next slide. So we do it when we see that a client is confused and we're unsure of what's going on because there hasn't been a previous diagnosis. We do it especially if somebody's a willing participant. We talk to them about what's happening. We don't just show up with a laptop. We let them know the appointment's occurring. So we look for them to be a willing and an active participant. Again, if they show signs of capacity concerns, this is a perfect opportunity to get them assessed. And we do have some clients that come with us with these concerns saying, yes, my memory isn't what it used to be. They are worried about some of the things that they're seeing and they just don't know where to begin to get some assistance. We also know that sometimes we can't get into a primary care physician in time. We have a ton of clients that we've worked with who haven't seen physicians in years. They just have been very forgetful, or they've been very reluctant to follow up with their medical care providers or just do routine medical care. And the case plan, obviously, after we discuss it internally, warrants that a further assessment needs to be done. Next slide. So we offer services. We recommend visits to see a physician, and we also increase family intervention if possible. If there are good people in our clients' lives, we try to get them involved as well, because sometimes we have people reporting on their own family because they don't know what to do with them, but they have dire concerns. Especially we see that with driving or when somebody starts to wander. The caregivers, sometimes they don't have any experience in this realm and they don't know where to turn to. The case gets open in APS for whatever reason, and then we try to work with them. If we're unsure of the capacity and these options are not feasible, or the client is refusing to see the doctor or is not able to go see the doctor, then we consider the virtual assessment, because we also have people with ambulation issues. They're more homebound. They have other concerns that they really don't come out of their home. And then the APS worker and the supervisor discuss this and say that there's need for further assessment. Next slide. So the virtual request is made and submitted to an APS department head. So it goes from the APS worker who will discuss the case with their supervisor. The supervisor and worker state that yes, more than likely, this is the track of or course of intervention we need to pursue. It goes to the worker, to the deputy director or the APS chief, and then it gets forwarded to the geriatric RN and or her unit members. We also check to see if there's information for insurance. We typically validate those allegations we're seeing. We also assess for the environmental and safety issues. And then we, talk about how we're going to do this visit. Will the APS worker go out with the nurse and do an introduction? Sometimes the APS worker and nurse go out on the first visit, or one of the behavioral health unit staff, because they suspect something is occurring. Next slide. So what happens? The geriatric nurse, she goes out to the client's home. She does a preliminary kind of scan of the environment. She takes vitals, she checks medications, she kind of looks at the food, the situation. Is there hoarding? Is it clean? Are there pets? Whatever the case may be, other people living in the home. She then schedules the appointment with the geriatrician for the virtual assessment. All the forms are prepped. The PCP is also contacted if we have someone on record to kind of coordinate any kind of potential services, or if it's a client that's in the Epic system, Dr. Factora can access sometimes those records and also coordinate physician to physician. And the RN usually goes out early. She talks to the person, she does all those preliminary things, tries to get them comfortable, and tries to set up her laptop and get them in the mode where they're ready for the actual assessment. She'll also do depression scale, she'll do the clock inventory or the clock face tool, and do some other things before the appointment begins. And she does converse very regularly with Dr. Factora, and they debrief and they talk prior to a case, and the APS worker is also brought in. Next slide. Some of the issues we may face, there have been technical issues. Technology is not fail-proof. So we have gone in a few times and there's been internet issues. We have hotspots on our phones that we access, but there aren't air cards built into our laptops, unfortunately. Physical concerns, we go in there with one plan and we find out that the person really needs medical treatment. And even then, if we have to have somebody transported to a hospital, we try to coordinate with the emergency departments or potentially catch somebody and ensure that a social worker, or if they're going to the clinic, have Dr. Factora kind of coordinate with somebody to ensure that that person, once they're cleared medically or triaged, that there are some mentions of the capacity concerns we have and what the initial APS involvement was or the purpose of the visit. We also do sometimes deal with clients who get frustrated. I think they know that we're catching on to something. They'll claim that they can't hear, even though they've done half the assessment. They get very upset with themselves if there are certain questions asked and they can't remember, or they're having a hard time coming to those thoughts. And we try to do whatever we can to take our time to ease their concerns and really do a lot of hand-holding and massaging of the situation. We also have a lot of clients, we see some dual kind of things going on, cognition as well as the mental health or substance abuse issues. And, from there, we continue to talk through what is going on with the capacity and memory issues. Next slide. So the benefits, all three parties coordinate. We've got our physician, we have our RN, and we have APS all working together with a common goal. The physician gets to actually see the client's living environment. Kelly, our nurse, can take, or the behavioral health specialist, take their laptop and screen the area. We make sure that if further testing is done, we help coordinate those appointments, get them into a doctor, get them established with somebody, or get them back into their regular practice with their primary care physician or whatever physicians they see. And then if necessary, a statement of expert evaluation is pursued. Next slide. So suggestions for replication: if you are able to do something similar, do your research. Baylor has a program. We have a program here in Cuyahoga County. I don't think it'd be that difficult to replicate, but also decide who in your area as a provider could participate. Talk with your probate court, see about where they feel this could go, especially since that's where guardianships happen. If you get these statements, see what their barometer is about doing this kind of a relationship. Find champions who can participate. Highlight the success stories that do come from this relationship, and we do work better together. This is very person-centered. Thank you.
Thank you. Our next presenter today is Dr. Jess Bibbo. Dr. Bibbo is a senior research scientist at Benjamin Rose and the Center for Research and Education. Dr. Bibbo earned their PhD in 2016 in Human Environmental Science at the University of Missouri. Since joining Benjamin Rose, Dr. Bibbo has been working on projects involving elder abuse prevention among older and/or disabled adults, including the training on abuse, neglect, and exploitation for the Senior Companion Program, grant funded by the Corporation for National and Community Service through the State of Ohio Senior Companion Program. Please join me in welcoming Dr. Bibbo.
Great, thank you, Ashley. So as Ashley said, my name is Jess Bibbo, and I'm going to be talking about some issues related to pet ownership, as well as benefits and challenges, not only encountered by APS professionals, but also a larger sample of interdisciplinary sample of professionals working with older adults. Next slide, please. Very quickly, I want to give credit to and acknowledge the Habry Foundation that funded this work. Next slide, please. So when we talk about pets and the meaning that they have in people's lives, most often we're really talking about the human-animal bond. And this is a bidirectional, mutually beneficial, and dynamic relationship between people and other animals. And this is influenced by the environment that they find themselves in. And it's also impactful for the health and well-being of all involved, the people and their pets. Next slide, please. And talking about pets in terms of healthy aging, there's a lot of work that's been done on the physical and psychological benefits of living with a pet, but healthy aging also entails being able to act on your own values and preferences. And for people who choose to live with pets, pets are often part of those decisions and part of those valuable relationships. And there's a growing body of evidence that pets can shape health behaviors as well as healthcare decisions in both some positive ways. So daily maintenance behaviors, as well as recovering from acute conditions such as a heart attack or a stroke. But as Natasha and Dr. Factora brought up too, it can also be a reason to refuse care. And so those are some things we need to think about when we think about pets. And pets also impact caregivers, both family and friend caregivers, as well as professional. Family and friend caregivers do instrumental work and helping their loved one's pets. So if a person is reliant on another person for care, they generally also need care in caring for their own pet. And this can also impact caregiver burden, but also satisfaction. And then in terms of healthcare and service professionals, pets are a great way to start communication, to build rapport, but there can also be some risks, especially for people who go into the homes, as Dr. Factora mentioned. Next slide, please. And for people living with dementia, pet ownership has not been studied as much as older adults living without dementias. There's much more evidence in terms of animal-assisted interventions, but I'm interested in people living in the home, which is the majority of older adults. But what work has been done has shown that being engaged with a pet, especially the care of a pet, can be very meaningful and important for people living with dementia. And pets can also provide a way to engage with the world around them. Pets offer very comfortable form of nonverbal communication as well as touch, and they can also be a vehicle for remembrance of long ago pets and stories and reminiscing. Next slide, please. So this study was to identify issues that people working with older adults have encountered, because there had not been a systematic study of this yet. And so we set out to identify not only the number of people who reported having encountered issues, but what those issues were. And so we also wanted to know specific benefits and challenges and resources provided by pet ownership in older adulthood. And this is not just for older adults, but also older adults living with dementia, as well as caregivers. And finally, we synthesized the results of this study to create consumer-friendly information, which I'll share with you at the end. And because I have a short amount of time, I'm not going to go into the nitty-gritty of all the steps and methodology of this. So I'm just going to give you an overview of what we did. Next slide, please. So the survey was an online survey. And again, we had an interdisciplinary sample of individuals, and we asked them about what they ask their clients about. So do you ask about pet ownership? We asked them to estimate the percentage of people they worked with that they estimated were pet owners. And then we also asked them about specific issues that they may have encountered. And these initial issues are at the bottom of the screen. And we also asked them to provide other issues that we may not have thought of. Next slide, please. And we also, because this was a really early study and there hadn't been work on this, we wanted to know, what have you seen? So we had 6 open-ended items asking about the benefits and challenges, as well as the impact on caregivers, both caregiving for people living with dementia as well as without dementia. And then we also wanted to know their own experiences. So you as a professional, what have you encountered? How have pets impacted you? And then we also had more of an additional item. Next slide, please. So this was our sample. We had 55 people who worked in adult protective services out of about 400 people. So, or 460 people were our whole sample, and about 55 worked in APS, so about 12% of the sample. And people working in APS were more likely to work directly with older adults, people living with dementia, and caregivers. They were also more likely than other people in the sample to have a full-time position, and more importantly, go into the homes. Next slide, please. And the reason that going into homes is so important is because we found that people going into homes were more likely to raise issues related to pet ownership. And we found that about 80% had encountered issues. And these can all be found in publication that is available in open access. Next slide, please. So again, we found that APS folks were more likely to ask about pet ownership than people who did not work in APS. Next slide. Even though they actually were no more likely to have clients that had pets. Next slide. And I'm going to hurry up because I see I'm running out of time, but some of the APS experiences, they were more likely to report issues that had to do with the pet's own needs and health. And they were also more likely to say that they had seen pets be a reason for refusing services. And that's been talked about earlier today. And I think that goes back to what Natasha said about the right to autonomy and that right to self-determination that is so important in APS. And also that APS and non-APS folks all primarily said that the major benefits were companionship and purpose, and the major challenges all stemmed from basic care, as well as the financial, veterinary, and pet waste was a big issue. Next slide, please. For people with dementia, we found that they were less likely to raise issues, but probably more likely to actually require assistance, and that they were doing more, and for the caregivers were doing more, and pets may have a larger impact on those folks. And in terms of favorability about pet ownership, all professionals were less favorable, not all professionals, but on average, people were less favorable about pet ownership in people living with dementia than older adults. Next slide, please. So these are the materials we made, and we'll make them available. They are on our website, and we'll make them available in the chat as well. And it covers pet ownership and aging, the benefits, challenges, and considerations when working with pet owners. There's also a box talking about people living with dementia. Next slide, please. And then we also made one for individuals who are working with caregivers of pet owners. And again, it's some of the challenges and benefits, but how it may impact caregivers specifically. Next slide. And here are some more resources that will be available. And thank you.
Thank you, Dr. Bibbo. Finally, we will hear from Ms. Courtney Reynolds. Ms. Reynolds is a licensed social worker. She is a Senior Research Analyst 1 and IRB Coordinator for the Center for Research and Education at Benjamin Rose. In 2019, she was part of a team that developed a mandatory reporter training for senior companion volunteers and supervisors in Ohio. From 2020 to 2021, she co-led the development of a mandated reporter training for real estate licensees in Ohio that was funded by the Association of Real Estate Licensed Law Officials. She is currently leading a project to develop an online training for Ohio's mandated reporters that is funded by the Ohio Bar Foundation. Additionally, Ms. Reynolds works on a team that is currently developing and testing interventions for self-neglect in Texas and Oklahoma and caretaker neglect in Utah. Please join me in welcoming Ms. Reynolds.
Thank you, Ashley. So hi, everybody. My name is Courtney Reynolds, and today I'm going to present on a training that Benjamin Rose Institute has developed for Ohio's mandated reporters of adult maltreatment, including those who work with adults living with dementia and/or disabilities. And before I get started, I just want to mention that although the training is geared towards Ohio, it can be adapted to reflect the laws of other states. And please reach out to me if you're interested in exploring this further. My contact information will be available at the end of this presentation, and I'll also put it in the chat in a little bit. Next slide, please. So we'd like to acknowledge the Ohio State Bar Foundation, which has funded the current iteration of this training. You can see that there are earlier versions that were also funded by the Corporation for National and Community Service Senior Corps, the Ohio Department of Aging with support from the U.S. Administration for Community Living, and the Association of Real Estate Law Licensed Officials, or ARELO. I'd also like to thank Chris Renison, Natasha Pietrocola, and Sylvia Pla-Wraith for their insights and contributions to the training, and Vicki L. Jenkins, the Associate General Counsel of the Division of Legal and Oversight, and her team at the Ohio Department of Developmental Disabilities for providing our team with information about mandated reporting of individuals with disabilities for this presentation and also the training. So the question that a lot of people have is, why now? Why are we creating an online training for Ohio's mandated reporters? And the first reason, could you change the slide, please, is House Bill 49. So in 2018, basically the number of occupational groups who were mandated reporters, specifically of elder abuse, basically doubled. And I should mention here that the focus of the online training is elder abuse and the laws related to it, but the reporting protocols that we provide, particularly in Module 2 of the training, which I'll get into, include all adults in the state. Can you go to the next slide, please? So in the chat, if you don't mind, can you just mention if you were somebody who received detailed training on elder abuse or mandated reporting of elder abuse or adult abuse specifically during a degree or certificate program, not your employment. So I see a lot of no's coming through. So if you're like me, I'm a licensed social worker. In social work school, I didn't get a whole lot of training on what adult abuse looks like, what my mandated, I was basically told you're a mandated reporter, and then that was it. Child abuse, on the other hand, I got a little bit more information. And I find as I ask people around the state and also around the country that question, basically they had similar experiences. Can you go to the next slide, please? So this slide looks messy. It's supposed to. It shows basically who mandated reporters are of elder abuse in Ohio and abuse of adults with disabilities in Ohio. And the groups, these are occupational groups. The occupational groups that are in yellow are specific to elder abuse only. The people who are in green are specific reporters for adults, abuse of adults with disabilities only. And the people in blue are people who are mandated reporters of both groups. And I show you this to show that this is confusing. It's confusing for mandated reporters to know who they're supposed to report about. It's confusing about understanding exactly what you're looking for, because if the definitions are different, it's just very confusing. Next slide. And that's one of the barriers to reporting adult abuse in general. If you look in the research literature, there's generally a lack of comprehensive training on abuse, which you all who responded in the chat with your own training just illustrated. There's also a lot of confusion about reporting laws, which to the previous slide's point was it's hard to know who's a mandated reporter of what. It's not necessarily clearly laid out for all of us. And then there are also concerns about the impact of reporting on a relationship with the client or their caregiver, their loved ones, and how the breach of confidentiality can affect that. Next slide, thank you. The third reason, which ties into the second one, is that Ohio's laws are complex and hard to understand. Well, we don't have protective services laws for people who are under 60 years old, although some counties may have resources to provide assistance to younger adults. People are screened in for investigation to adult protective services based on their age, their living arrangements, and then also whether they have an impairment or not. And adults diagnosed with a disability before 22 years old can get services from the local Board of Developmental Disabilities. But outside of that, it's hard to know who to report to and where. So all these things point to the need for standardized training across professions, online training that's easily accessible and on demand, the ability to log in and log out as you need because we're busy and we need to be able to come back to the training as we can process it and understand it, the ability to assess for change before and after a training to make sure that what is being learned is in fact what should be being learned by the training, and then the need for a training that was developed by an organization with expertise in the field. And so Benjamin Rose has a long history in the field of elder justice and also in developing these types of trainings. And so we have created such a training. Next slide, please. So this is an overview of the training that we have created. It includes 2 modules. The first module provides a background on abuse, and that basically goes over the definitions of abuse, and also why mandated reporters may not report. Sorry, can you go back? And the second slide, the second module is about recognizing and reporting abuse. And that includes where and when to report cases of abuse and contact information for reporting agencies. It includes a reporting protocol. So the overall training goal for us is to help mandated reporters. It's to help them understand their legal responsibility to report when they have reasonable cause to suspect that abuse is occurring, regardless of their perceptions or beliefs. It's to help mandated reporters be able to identify abuse and the signs of abuse that suggest it could be occurring, and also to know where to report it. Next slide, please. So this is just a screenshot of a tool that we give access to is in module 2 of the training. It is a tool that was developed at the Benjamin Rose Institute on Aging. It's called the Recognizing Abuse tool, and it basically involves, it can be a direct question used to directly question individuals who you're concerned may be experiencing abuse, or it can be used as an observational tool to recognize the signs of abuse. And basically it can tell you whether you should have suspicion of abuse. And then there's another tool that we include in the training in the second module next slide, please, which is the reporting protocol for adult abuse. And this basically simplifies, it's a flow chart that simplifies what mandated reporting looks like and where you should report it in the state of Ohio. Next slide, please. So there is a cost to taking the training, and the reason that we are charging for the training is to maintain the learning management system platform that we're using, and also to offer continuing education hours. And so the first module is $10, the second module is $15, or you can take them both for $20. Next slide, please. We do have approval to offer social work CEs, nursing CEs, and continuing legal education hours. And if you have any questions about the approval status or contact hours for other disciplines, you can contact me. Our goal in the future is to offer additional groups, CEs as well. So to access the training, you go to that website, the benrose.academy.reliaslearning.com, and we'll put that in the chat. You would create a free account on that site and then click on the mandated reporter training tab to purchase the modules. You would then purchase the modules and take the training. If you have any questions or after the training, think of something, or sorry, after the presentation, think of something that you'd like to ask, please don't hesitate to reach out to me. That is my contact information. And I thank you very much for your time. At the end of the PowerPoint, there's some selected references if anyone's interested. But otherwise, Ashley, take it away.
All right, thank you, Courtney. And thank you to all our wonderful presenters this afternoon for all the insightful and engaging presentations. We're very excited to be sharing this information. We do have time for a few questions from the audience. I know that quite a few have rolled in. If you haven't already submitted your questions, just go ahead and submit them either in the chat or you can submit them in the Q&A. So we do have several questions that are geared for specific presenters. So to start with, just right now, Courtney, we did have a question come in. Is the training available now?
Yes, we're excited to announce the training is available. And I believe Megan just put the link in the chat.
All right, and just scrolling back all the way to the beginning, Dr. Factora, this would be for you. Do you or APS evaluate elders living in assisted living or memory care communities? And Natasha, you could chime in too.
Yeah, we do the assessments for anyone that's of concern. In person, the virtual capacity evaluation can actually be done at any location. Natasha, you can really comment to referrals for individuals who are in assisted living or more supervised settings, but I don't think that that's necessarily a barrier to conducting these evaluations.
We've done some where people are in a skilled facility more recently, and they're not necessarily going to be their long-term care, but we suspect when they open the case that this is where it was headed, and we've done stuff to that level. But the thing is, if somebody's in a long-term care facility and they've been established there as a resident in the state of Ohio, we don't have jurisdiction in those facilities. So really, if they're a resident, they should be looked at by their own medical providers within that facility. But there are some circumstances where APS is involved and a client ends up there for whatever reason, and we're still connected to the case, or it just depends on the circumstance, but we have done it, yes.
Thank you. And Natasha, this one's also for you. It says, how have staffing shortages and overload affected the ability of APS to complete thorough or timely assessments?
We're a little fortunate in the part of Ohio that we hail from. We're in Cuyahoga County, which is the Cleveland area. We probably have the most resources as far as staffing. I've got 30 APS social service workers and 5 supervisors. But the supervisors are pretty vigilant. People can't just close a case because they're suspecting one thing is happening or another. We do ask questions, and I think adding a nurse in the behavioral health unit has been beneficial. Gives another set of eyes, a perspective, and we also have a very thriving adult protective service collaborative, which is our I team. So we talk a lot about community cases that maybe haven't come to our attention or cases that we're struggling with in APS. Where we see the biggest problem is truly with people who have capacity and choose very questionable lifestyles that make all of us very uncomfortable. But they don't want the help. Sometimes we have people that are on a cusp where they're kind of able to make decisions, but we know probably in the future they'll become adult protective service clients, and then we have to reopen a case. So it's very case by case, but we do the best we can, and I think, and like I said, we're fortunate we have enough social workers to go out and do these investigations.
Thank you. And this one can be open to the group, whoever would like to chime in and answer it. It says, are STNAs or CNAs considered mandated reporters?
Yes, they are.
Thank you. All right. And this one is related to pet ownership. It says, what happens when an elderly couple are ill and cannot take care of their dogs anymore?
Well, there's no, real organization to pick that up. Often pets can be either relinquished to a shelter, but really what that comes down to is the need for planning and having planning conversations with people in your either caregiving network or family, friends, neighbors. There's no one thing that happens. There's many things that may occur, some of them good, some of them not as good. So having those planning conversations is very important.
Thank you. So if anyone would like to post any more questions in the chat, I know that there were several that kind of got mixed in the answers there. This one says, where's your forensic nurses program and why did you choose the forensic area? I'm not sure if that one was supposed to be for Natasha when she was talking about hers.
From what I could gather, it seemed like somebody was asking that of somebody before me. That was
okay.
Forensic nurses. I have a regular RN. I think it was
Okay.
in Maryland, maybe, that said that they use some program. I'm not sure.
Thank you. This one was specific to Dr. Factora. Why do you choose the slums as opposed to the MOCA?
So we use the slums because that was actually the one that was used in the initial program that we actually duplicated. So when we had actually picked up the program, talking with Natasha and the APS in Cuyahoga County, that program was already up and running. They had published that particular model. So we used that model, which utilized slums. It doesn't mean that you couldn't use MoCA. There are differences in the cognitive testing in terms of the sensitivity, specificity, and who they are actually validated for. So if you use the MoCA, you have to understand that the validated cohort tends to be higher educated, typically with a bachelor's degree. It may be a lot more difficult to implement actually on a virtual platform because it does require a lot of guidance one-on-one. There is training that is recommended for implementation of the MoCA. Not that you could do it without, but I think it's good to do it properly as opposed to the slums and the mini-mental, which may not have that kind of level of training. So the short answer is it was set up that way, and that's why we use the slums. But you could use any kind of cognitive testing you want. For this type of program, you just have to make sure that it is easily implementable on a virtual platform.
Thank you. And also, Dr. Factora, when you were presenting, a question did come in asking if social cognition was assessed at all.
Okay, so that's a good question. With regards to that, my understanding about social cognition, really you're talking about internal processes for the individual overall. And not to say that that can affect functional status, because it can, and it can affect a person's decision-making. That is not something that we actually assess as part of this evaluation. We're specifically looking into cognition, domains of cognition in the traditional sense, as opposed to social cognition, and specifically interested in the way that a person's cognitive function affects their ability to interact with their environment and looking for any deficits to that degree. So not to say that social cognition couldn't produce functional impairment. It's just not an area that we actually assess with this particular program.
Thank you. Okay, so before we conclude today's webinar, our project director, Dr. Jess Bibbo, is going to tell you briefly about BRI Care Consultation. It's a care coaching program available for families impacted by dementia in various counties in Ohio through the Administration for Community Living Project. Jess?
Great, thanks, Ashley. So BRI Care Consultation, as Ashley mentioned, it's an evidence-based program that was developed here at Benjamin Rose, and it's delivered by telephone and email. It's a care coaching program that assists and supports adults with or at risk of dementia, as well as their family and friend caregivers. Next slide, please. So a personal care consultant connects with people, either caregivers as well as some care recipients who are in the program, and connects them with resources, helps them with communication tips, also assists with difficult conversations, as well as getting other family and friends involved, so expanding that support network. And they also provide emotional support. Next slide, please. And so these are our current grant partners on this grant that are involved in BRI Care Consultation. We're very excited that they come from all over the state of Ohio. And we're also serving individuals with intellectual and developmental disabilities or who are at risk of developing dementia in this grant. So thank you very much. Back to you, Ashley.
Thank you, Jess. So we want to thank our wonderful speakers again, and we would like to also thank you for joining us today for Collaborative Approaches in Elder Justice for Protecting Adults Living with Dementia or IDD. As we mentioned earlier, a recording of today's session and the PowerPoints will be made available at www.benrose.org on the event registration page and in our resource library. You will also be emailed a copy. Please feel free to share today's webinar with your family, friends, and colleagues. We are offering more webinars like this for community organizations and families impacted by dementia each quarter of this ACL project. Our next one will be on December 12th from 12 o'clock to 1 o'clock. It's Every Time I Hear That Song, the Impact of Music Intervention on Engagement and Socialization in Persons Living with Dementia. We would also like to invite you to join us for our upcoming in-person annual caregiving conference, the Ohio Alzheimer's and Related Dementias Resource Program, which will be held on December 8th from 9 a.m. to 3 p.m. It will be held simultaneously at the Benjamin Rose Conference Center here at 11890 Fair Hill Road in Cleveland, and at the Golden Buckeye Center for Dementia Caregiving, which is 760 Kinnear Road in Columbus. To register for the conference and stay up to date about all of Benjamin Rose's upcoming events, please visit our website. Again, it's www.benrose.org. In the chat, you will see a link to a post-session questionnaire. You will also be receiving it in email later today. We ask that you please complete the post-session questionnaire within 1 week following today's session. Your responses and feedback will be used to show the impact of programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. We thank you for joining us today, and we hope that you enjoy the rest of your afternoon. Thank you.